Okay, so we might just make a slow start, I think. So I'd like to welcome everybody this evening to our session on catch-up immunisation for everyone, children, adults, adolescents, with a special focus on refugee populations. So I'll just share my screen and we'll get a slow underway. Okay, here we are. So, my name is Natalie Simpson-Stewart. I am a Quality Improvement Program Officer at Northwestern Melbourne Primary Health Network, and I'll be your facilitator this evening. I'm so excited to have everyone with us. My other life as a nurse working in a clinical setting, immunisation catch-up is something that's very close to my heart. So I'm very excited to be able to present this evening with some really wonderful presenters. So we're just going to start with a bit of housekeeping. So we're so fortunate that this is a lovely collaboration between a whole bunch of parties who are all on the same page with wanting to get everyone's immunisations up to date. So myself and my colleague Yvonne from Northwestern Melbourne Primary Health Network, we also have representatives from Southeastern Melbourne Primary Health Network underneath the auspices of the Victorian Tasmanian PHN Alliance. We also have a presenter from Cancer Council Victoria and two presenters from the City of Greater Dandenong. So some really fantastic things going ahead this evening. So I'd like to begin with an acknowledgement of the traditional owners of the lands on which we're meeting tonight. So for us at Northwestern Melbourne Primary Health Network, we are on the lands of the Wurundjeri people, the Bunwurrung people and the Wathaurong people. I'd like to pay my respects to their elders, past, present and emerging, as well as extend a warm welcome to any Aboriginal or Torres Strait Islanders who are with us this evening. So a little bit of housekeeping to begin with. So you'll all notice you've been invited in on mute. So if you do have any questions, please jump in the chat at any time and pop them in there, and we'll take pauses throughout this evening's presentations to pose those questions. It is being recorded. Post the session in the next day or so, you will receive a copy of the slides. Obviously, if you have any questions, you're more than welcome to send us an email if there's something that you forgot to ask in the time, and we can follow that up for you. Big thing is, in order for us to take attendance, particularly for those general practitioners with us this evening who would like your RACGP points, it is really important that your Zoom name matches the name that you registered with. If you're not sure how to change your Zoom name, down the bottom in the chat box, if you just change that over to a direct message to Northwest Melbourne PHN Education, we could give you the instructions on how to change that name. Okay. So kicking off, we have some wonderful presenters I'm so excited to introduce you to. So this evening, we will be starting with Alice Bastable, who is the Cervical Cancer Elimination Manager at Cancer Council of Victoria, who's here to talk to us about HPV vaccination and how exciting it is, how close we are to the elimination of cervical cancer in Australia, which is really exciting. We also have Dewani Patel and Heather Johnston, who are both digital health project officers. So Dewani works with us at Northwestern Melbourne, and Heather is kindly joining us from Southeastern Melbourne Primary Health Network. Then for the meaty bit that we're all here for and very exciting, we have Kate Russo and Mina Delili from the City of Greater Dandenong. So have both been working in the Refugee immunisation program. You may have heard of it as PRIME, which unfortunately ended at the end of last year. So they have come to share their absolute font of knowledge with us all so that we can continue the amazing work that they've been doing. So before we kick off, everything that we talk about this evening, and there's going to be a lot of information and we don't expect you to be able to remember it all, I'd really just like to highlight health pathways. So for those in Northwestern Melbourne PHN catchment, you're probably very aware of it. What it is really clear, concise, evidence-based health information. And the idea is about trying to make it easy for practitioners to do that really good quality care at the bedside, at the computer. It also contains referral pathways, so both for Northwest Melbourne, also for Eastern Melbourne as well, and what services are available in those catchments. It's a really easy website to navigate. There's a lovely search bar, or if you're not really sure and you just want to have a bit of a browse through, you can always scroll through down the side as well that will go through topics. So we can see for this evening, immunisation sits under public health, but you can also just type it in the search bar as well. When you're opening your health pathway, what it will actually go through is basically woe to go. How do you look after that patient with this particular thing? So in terms of immunisation, it goes through catch up at each of the age stages, also routine childhood immunisation as well. In terms of management of complications and also any referral pathways and with links to other places that you might need to refer to. If you see something you don't like in Health Pathways or you'd like to give us some amazing feedback, there is a send feedback button on the bottom of each page, which will come directly through to our team. And there is a list here, which again, you'll get the slides tomorrow or the next day, and that goes through all the relevant pathways that we'll cover across lightly this evening. Very easy. melbourne.healthpathways.org.au. You can choose to register now, and that will provide you a link that is specific for your computer so that you don't have to go through the login process every time. There is also a QR code there as well that will take you to the website. Wonderful. And with that, I'm going to pass over to the delightful Alice, who's going to take us through HPV elimination.
Wonderful. Thanks, Nat. I'm just going to get my presentation up, so bear with me. I'm usually cursed with these sorts of things, so let's hope this is working.
We can see it.
Wonderful. Actually had my CEO of the organisation on his bending down on the ground trying to fix a slide for me in a meeting the other day because I'm that cursed. So is everyone up? That's in presentation mode. We're all good?
Yes, it is clear.
Perfect. Wonderful. Okay. Well, thanks, everyone. As Natalie said, my name is Alice Bastable. I work at Cancer Council Victoria, and I'm here tonight just to talk briefly with you about some important HPV vaccine updates, what Cancer Council Victoria is doing in this space, and how you can help promote HPV vaccination with your patients and in your community. So firstly, I thought I'd just set a bit of context. Where does HPV vaccination sit within Cancer Council Victoria? It sits within our 5-year cervical cancer elimination strategy, which is a 5-year, I guess, combination of activities like projects, mass media campaigns, media and PR activities, research projects, and community and healthcare professional engagement sessions that really address 3 issues. 1, cervical screening participation. 2, access to treatment for those who need it. And 3, HPV vaccination. So I work with a team of people across Cancer Council Victoria to do all 3, and I'll be talking a bit more about strategic priority 3 today. So firstly, it's probably not lost on you how effective the HPV vaccine is. It provides fully vaccinated people with protection against 9 types of HPV, including types 16 and 18, that are the 2 most common types associated with HPV-related cancers. The next 5 most common HPV types associated with cervical cancer, and the 2 non-cancer HPV types that are, which cause over 90% of genital warts. Last February, the Australian Department of Health and Aged Care announced the change or some changes to the HPV vaccination schedule, namely from a 2-dose schedule to a 1-dose. But what they also did was extend the eligibility for the free vaccine. So now what we're looking at is the HPV recommendation is recommended for people aged 19 to 25. However, is only free for people aged 12 to 25. Most people now only need 1 dose, but some people may need 3 doses, particularly those with significant immunocompromised conditions, or those that do need the HPV vaccine but are over the age of 26. The HPV vaccine is also recommended for other people that are at higher risk of developing HPV-related diseases, as mentioned, those with significant immunocompromised conditions, or men who have sex with men. Most people in Australia get the HPV vaccine through the National Secondary Schools Immunisation Program, which is run through schools across all states and territories, and it gives the vaccine to people at 12 to 13. But a lot of people now with that extended age eligibility for the vaccine are going to be getting their vaccines elsewhere. There was a recent study that came out in January this year. I'm not sure if anyone has seen this, but it really does reinforce how effective the HPV vaccine is at preventing cervical cancer. This study examined cervical cancer incidence in Scotland and found that there were actually no cases of invasive cervical cancer recorded in women who had received the HPV vaccine at the age of 12 or 13, irrespective of the number of doses that they'd had of the vaccine. The study also found that women who were given the HPV vaccine at older ages, so 14 to 22, had significantly reduced incidence of invasive cervical cancer compared to those that are unvaccinated. So I guess we're at a time now where we're actually starting to see real world outcomes on cancer incidence with the HPV vaccine, which is really exciting. And you can get that article there from the link. Thought I'd just cover a couple of the really interesting stats that were published in the annual immunisation coverage report from NSERS that came out late last year. What you can see on the chart here, and these are all available in that report, is that we're starting to see a slight decrease between 2021 and 2022 in HPV vaccination rates across girls, boys, and Indigenous girls and Indigenous boys. This effect is really more pronounced when we look at socioeconomic environment difference and also across Indigenous populations as well. So the data here is showing those in 2021 and 2022 who were by the age of 15 getting 1 dose of the HPV vaccine. The report also highlights how Victoria is doing compared to the rest of the country. And again, we're seeing quite a similar picture in Victoria, that with a slight decrease in vaccination uptake of 1 dose by the age of 15 between 2021 and 2022, obviously the pandemic most likely playing a role there. And we're really seeing this effect more pronounced in Indigenous Victorian girls who are appearing to have a larger drop between 2021 and 2022. Again, in this report, it's got great data, if you've not seen it, about 1 dose coverage at the age of 15 across CEFA quintiles. So looking at socioeconomic status, we're seeing large variances at about 5 to 10%. Between those living in the least advantaged environments compared to those from the most advantaged environments. And again, this effect is more pronounced in Indigenous girls and boys at the age of 15. And again, really great data in this report, looking at cohorts extending past the age of 15. So what we're seeing here is the people who were turning up to the age of 26 in the year 2022, and the coverage of anyone of at least 1 HPV vaccine dose being given by females. So what this is really telling us is that vaccination of HPV does tend to peak at the age of 19, but you start to see a pretty big drop at the age of 20 to 25. Because it is 2022 data, you'll see those aged 25 and 26 in this chart have actually kind of aged out of that free eligibility now, but it does highlight that there's a lot of people walking around out there who are between the 19 and 25 who haven't had that HPV vaccine. So a good prompt for catch up. So that's the females by birth age, and this chart is males. And what you'll see here is obviously similar sort of pattern of coverage peaking at the age of 19, then dropping off. We see that this drop off between the age of 20 and 25 is significantly sharper, and the numbers are lower in males, and that reflects that they were obviously added to the HPV vaccination program at a later stage than females. Another, I guess, reason across males and females with this drop-off is the fact, I think, largely put down to migration, so people who have moved here after they would have got the free vaccine at school. So again, screening for anyone over the age of 19, but also those that might have migrated here and missed out during school. So again, you can get those charts and that data from that report. It's a fantastic source of information and on coverage and rates across Australia. I just wanted to now talk about, I guess, what Cancer Council Victoria is doing in this space. We oversee the National Cancer Council HPV vaccine website. Is a really great source of information, not only for your patients and your community, but for you as healthcare professionals as well. A really good range of information on the site. So if you've not been on it, I'd certainly recommend taking a look. The website address is there. We've got a really great suite of resources on the website that are available for you. We've got fact sheets and animations and social stories for adolescents with disability and their parents, as we recognise they face unique barriers to HPV vaccination. We've got posters and brochures for Aboriginal populations. And we've got just fact sheets about the HPV vaccine in plain language and just animations that are about 2 or 3 minutes that can be shared for teens, but also their parents as well. There's really great facts and questions that we commonly get asked, and these have all been reviewed by a clinical expert on the HPV vaccine, so they're a really trusted source of information. So do have a look at the website if you're ever getting any curly questions, because we've probably got the question listed there. And I'll just finalise by, I guess, talking about some of the work we're doing under our elimination strategy this year to promote HPV vaccination in Victoria. So we've recognised that there's been slight declines in vaccination in 15-year-olds, and we know that there's I guess quite a large proportion of people between the age of 19 and 25 who are potentially unvaccinated. So we're doing a series of a couple of campaigns this year to really get the message out there about the importance of the vaccine, the effectiveness of the vaccine, and the new age eligibility and that ability to catch up for free. So we recently did a burst in February where we highlighted some of the data from that NSERS annual report. And we've got a fantastic stakeholder kit to support that campaign with newsletter copy, social media copy, and social media tiles. So if that would be of any use to your organisation, you can grab a link there, and I'll post that in the chat as well. Just really good to kind of spread the word amongst your communities. That's just a bit of a summary of some of the media coverage we got for the burst one of the campaign in February this year, including pickup from the Age, or the Herald Sun, not the Age, the very opposite of the Age. And we've got some upcoming campaigns as well. So I'd really like to just end on, I guess, putting a bit of a call to action to everyone listening tonight about your role in helping to promote HPV vaccination uptake. So we know that, there's a significant amount of people out there unvaccinated, particularly in those older eligible cohorts. So screen your patients and offer HPV vaccination if needed, particularly in populations that might have migrated over and missed out in school. Please support our upcoming CCV campaigns. We'll be doing 2 paid campaigns this year, one targeting 18 to 25-year-olds on TikTok midway through the year, and the second targeting parents of teens 13 to 18, just about anyone who's got a child who's missed out on the HPV vaccine over the last few years. We'll be developing similar sorts of stakeholder kits, so please reach out if you'd like to receive one and I can add you to our list. Thirdly, we're always after case studies, so if you've got a good case study or you want to highlight a success story or do some advocacy work with us, please reach out. We're always open to that. And fourth, just if you've got any ideas about what we should be doing in this space, we're halfway through this strategy. We've got I guess, a healthy amount of funding, and we're really open for collaboration as well. So please reach out if you've got any ideas, but I'm going to leave it there. Happy to take any questions now if anyone has any, and I will pass over to Nat to facilitate any questions.
So just one question, just around, and this might open to Kate and Mina as well, the position of the Cancer Council, given the recent changes by the Department of Health around eligibility for HPV vaccination. So the question about, if there is no Medicare, the vaccine's not free. Obviously, there are some, which we'll be going into later, there is some grey areas under eligibility, and it is included in catch-up. But I was going to say, if you wanted to speak to that, Kate or Mina or Alice.
Kate, I'll hand over to you for that. But I think before I do, it has been something I think we've Cancer Council Victoria does have a position of advocacy, and we do submit to some of these higher level policy documents here and there. So I think it's something we're very mindful of, this inequity of cervical cancers and other HPV related cancers, that it really is an entirely preventable cancer, cervical cancer, if you can get people vaccinated and screened. So it's certainly something that we would be willing to advocate for if there was an appropriate channel that you can suggest. We've certainly done it in the past.
Yeah.
So Kate, I'll hand over to you.
Yeah, it is really awkward at the moment, because technically we're meant to be asking if they are Medicare eligible. If you're reading the what the Department of Health have said, it is of course funded for refugee and people seeking asylum, and maybe if there's been other vulnerabilities or children that have missed out up to the age of 20, they can be funded. And I don't think it rolls over to 26 for HPV. It's because the eligibility criteria is talking about all NIP vaccines. We've identified it as a real risk in the city of Greater Dandenong, because we have a lot of our population are migrants that don't sort of fit into any of those categories. Our coordinator has been all of us have been advocating whenever we've had the chance, because I don't mean to make fun of it, but we often have a joke to say, oh, maybe if you're a migrant, you just don't get cervical cancer, but we know that that's not true. It's just we feel that there's a whole portion that are going to miss out, since they've really clamped down on that Medicare eligibility. And I know that, if you don't ask, you don't know about the Medicare eligibility, but technically if there was an audit or something, it could be quite tricky. So it'd be great, anybody that's on tonight, if anybody can advocate for that in any of the avenues that they can, that would be really good, because at the end of the day, it's cheaper to prevent than to treat. So yeah, so thanks, Alice, for that. Mina, do you have anything? Okay.
All right, wonderful. Well, we've been very lucky to have Alice with us this evening, so I'd like to thank her very much for her time and leave her to go and wrangle children, as most of us have to do. So thank you very much. I'd now like to hand over to Duani, who's going to take us through the technological support that's available through digital health to help us do our catch-up schedules. So thanks so much, Duani.
Thanks, Natalie, and thanks everyone for joining today's webinar. So I'm going to share my screen. Just bear with me. Oh.
See your screen.
Is it coming up okay?
It is. It's coming now. Yep, perfect. You're in presentation mode.
Thank you. Thanks, everyone. So my name is Dwani. I work at Northwestern Melbourne PHN. And today I'm going to present on my health record with a specific focus on the immunization information. So in terms of presentation overview, I'm going to talk about overview of my health record, different documents which are available through my health record, and the different views as well. Benefits of viewing immunization details through my health record. And we have also received few important resources from the Australian Digital Health Agency, which are just a short video clips which would demonstrate you how you can access immunization consolidated view from the different clinical system. So we'll just play a couple of video clips just to show you what steps you need to take. Also, I'm going to touch on the patient education piece, which is My Health application, a little bit about My Health record statistics, and the learning resources and the support. So what is My Health record? So My Health record is an online summary of an individual's key information, and it is personally controlled. So the person or the individual can decide like how often they would like to interact with My Health record. It is really up to the person if they want to manage their record or not. There is also option available if they want their family member or carer to manage their My Health record, because sometimes we have seen some people, they are not very confident with the management of their My Health record. So in this kind of scenario, they can always ask their family members to manage their record. There are also certain settings available where they can manage the access. For example, if they want to give view only access, where their family members can only view the information and they can share across the healthcare providers, or they can allow their family members to change the health information on their My Health record. So it is very much personally controlled, and there are different settings available where they can manage their My Health record. It is part of the national system, which is available 24/7. And it is accessible via all the authorized healthcare providers, as well as it is protected with the higher level of cybersecurity and the specific legislation. So this legislation essentially protects the misuse of the information in the My Health record. So in nutshell, this is just a very brief overview of My Health record. Now, what is available in the My Health record? Like which documents are available? So I'm not going to go into details, but essentially they can be divided into three categories: consumer documents, provider documents, and the Medicare documents. So the consumer documents, where patients can upload different documents on the My Health record, for example, personal health summary, personal health notes, etc. Provider documents are the documents where healthcare service providers can upload the patient documents, such as share health summary, pathology reports, event summaries, etc. Medicare documents, they are essentially linked with the Services Australia, and there are different documents available, for example, PBS claim, Australian immunization register records, and the organ donor registration register status. In the middle of the screen, you will see there are like 5 different views listed: Medicare overview, immunization view, pathology reports overview, and the medicines information view. So these are not actually the documents which are uploaded by the healthcare providers, but these are essentially a system generated dynamic view, where the system would extract information from the uploaded documents, and it will generate the consolidated view, which can be really useful for the healthcare providers. For example, pathology reports view, where there are different pathology results are available in a single view, and the GPs or the other healthcare providers, they can group the records as per their needs and requirements. So I'm going to touch a little bit on immunization view in this presentation. So on the screen, you will see there is a screenshot of the immunization consolidated view. This view is very easily accessible from most of the clinical system, which are conformant with the My Health record. So there are a lot of benefits of viewing immunization view through the clinical system, such as it gives you the information about the status, any due, overdue, or upcoming immunizations. It is also very useful for the parents to keep up to date with their child's immunization. Within this view, there is one additional section available from the Australian Immunization Register, which is the notices section, and it includes the information such as recorded medical contraindications. So it is a useful view, and in nutshell, it is very easily accessible if your clinical system is conformant with the My Health record. So in the next slide, we have got a short video clip, which particularly demonstrates how you can see the immunization consolidated view from the best practice software. Again, we have received this video resources from the agency. And the following video, it is just a 50-second video, which apparently shows how you can upload the patient share health summary. So I'm going to play these two video clips, and we have also other resources are also available, so which we have also put that in this presentation. So is the sound coming okay? All right.
The Immunisation Consolidated View displays details of a patient's immunisations that are recorded in the Australian Immunisation Register, as well as shared health summaries or event summaries available in the patient's My Health record. To access this information, open the patient's My Health record document list and select Immunisation Consolidated View. At the top of this immunisation view is the navigation panel. The default view displays immunisations that have been recorded in the Australian Immunisation Register. Information listed here will include the date of vaccination, dose number, brand administered, and the indication. Next, Immunisations Due section will display when the patient may be due for a follow-up vaccination. The next tab is Immunisations. This will display a consolidated list of the patient's immunisations as recorded in both the Australian Immunisation Register and in some My Health record clinical documents. These documents include shared health summaries and event summaries. If an immunisation has been recorded in both sources, it will appear twice in the list with the relevant colour code to indicate which source the information originated from. For example, one of the patient's vaccinations was recorded in the Australian Immunisation Register as well as a shared health summary. When the immunisation information is sourced from a clinical document, you can click on the blue hyperlink to view the entire source document. The next tab in this view can link you to the most recent shared health summary in this patient's My Health record. If this document is available, it can provide you with information about the patient's regular medications, medical history, allergies and adverse reactions, and immunisations. The last tab in the panel is the event summary. A link to this document will display if the event summary contains immunisation information.
How to upload a shared health summary. Select Create Shared Health Summary from the My Health record menu. The Shared Health Summary window will open. The Shared Health Summary is uploaded by the patient's regular healthcare provider and represents their health status at that point in time. The Shared Health Summary window allows you to remove items you do not wish to include in the Shared Health Summary by deselecting items. Click the Preview button to continue. Review the summary and then choose Upload. The Shared Health Summary is uploaded to the patient's My Health record and appears in the document list.
Thanks, everyone. So similar to these two videos, we have received other resources as well from Australian Digital Health Agency, as I mentioned earlier. So all those short video clips, they are available in this presentation. So once you receive the copy of your presentation, you will have access of these resources. If you think there is something which is not available or something you're looking for, please feel free to reach out to myself or Sonia, and we will liaise with agency to develop that educational resource for you. But it is a short video resource, and it can be really, really useful. In this slide, I just wanted to touch base a little bit on the My Health application. So My Health application that was launched by Australian Digital Health Agency last year. It is a very useful application for the patients, and it is useful for any individuals because they can view their medical history, pathology results, hospital discharge summary. They can also manage their immunization um, and the vaccination through this application. This application also allows them to share the documents with their healthcare providers. So and the Australian Digital Health Agency, they are planning to add new functionalities as well. So we would highly encourage you to educate your patient to download this application and take the advantage of this application. My health record statistics. So I also wanted to show I also wanted to show you a little bit about the My Health record statistics, especially with the documents upload and how documents are getting uploaded. So these are some of the graphs from January 2023 to January 2024. So you can see there has been huge increase in the specialist letter upload, which is 76%. 46% increase in the medicine documents, and the pathology reports are increased by 38%. So I just wanted to put this piece of information because it is a very, very positive outcome, and it has shown a very positive trend. And hopefully it continues this year as well. So we would highly encourage you to continue using My Health Record and keep uploading these documents. If you're interested in other statistics and other data sets, some of the other information is also available on the agency's website. And it is a very interesting data. So I would encourage you to look out the other data sets as well. Now, lastly, I just wanted to show you how you can stay up to date with the digital health. So there are multiple educational resources available where you can keep yourself up to date with the digital health. For example, e-learning modules. Agency also runs webinars on a regular basis, so you can register for those webinars. There are recorded webinars as well available on their website. There is a YouTube channel as well as the digital podcast available. There are also specific to your clinical system. There are also software summary sheets available. And if you are missing anything, please reach out to us, and we will liaise with agency to develop those resources for you. And lastly, this is just information about the My Health Record helpline. If you have any question about My Health Record, you can certainly reach out on this helpline, and there is an email address as well. So with that, that's the end of the My Health Record presentation. And I will hand back to Natalie if we are taking questions, or I'm not sure if we are doing at the end of the session.
Wonderful. So if anyone does have any questions, feel free to pop that in the question and answer section, which is at the bottom of your Zoom screen, the two little message bubbles. Thank you so much, Dewani. I think it's really exciting to see My Health Record starting to move towards what it was envisioned to be. I know certainly patients of mine that have it really enjoying being able to actually view their health information and have that control over it. So it's a really exciting time. And as all those people out there with their e-health practice incentive payments know, very important to be uploading our shared health summaries and making sure they're accurate. So thank you so much for your time this evening. All right.
My pleasure.
So moving on, the main event after what a beautiful set of entrees we've had. So Kate Russo and Amina Dalili from City of Greater Dandenong here this evening to talk us through catch-up schedule creation. That's very excited. Welcome.
Thank you. Hi, everyone. So if Dwayne wants to just stop sharing, I think we can share.
You can just share over 20s. Okay, you can just start sharing.
Okay, sure, no worries. This one. Okay, can everybody see that?
Yes.
Yes, that's great. Thank you. Thanks, everyone, and thanks. There's a few online we can see, and thanks for the previous presenters as well. So Mina and I are happy to be here tonight to talk to you as well. I did see another HPV question, I think, in the chat regarding oral cancers from HPV. They just anecdotally, to the person that asked that question, they are finding there has been quite a decrease in HPV positive cancers of the upper respiratory tract and ENT. So that it is proving to be quite protective for those that were caused by HPV. Of course, those caused by smoking and alcohol use are still at the same percentage that have been previously. But the research is coming on that too. So I just thought I'd answer that question as well. Thanks everybody for having us. So we're from the City of Greater Dandenong, the City of Opportunity, and we're presenting really from our, I guess it's mostly from our perspective of working with the local government. And as was mentioned earlier by Natalie, we used to be part of what was called the PRIME project, which was the Program for Refugee Immunisation Monitoring and Education. And last year, the funding was ceased for that. We had seen close to 6,000 clients come through for us in the southeast, and over in Hume, Whittlesea also were running a similar program. Their cohort was mainly to do with the people coming from Syria, and we've been mainly working with people from Afghanistan and Burma or Myanmar, just to set the scene in that space as well. But as was mentioned, our funding has been ceased. And sometimes it's hard with bean counters. They see that we've got really good immunisation rates, but we always have new people arriving and new babies being born. So the need never really leaves. I'm just moving ahead now. We'd just like to acknowledge that we're talking to you tonight from the Bunurong, the land of the Bunurong people, and pay our respect to their elders, past and present, and we recognise and respect their continuing connections to climate, culture, country and waters. So just a little bit about the City of Greater Dandenong. For this session, we're covering around catch-up immunisation. Also, we've got some questions coming up later that would be, if that's okay, Natalie, if we get people to pop things in the chat and you can read out any answers. We don't expect you to read 114, but I do expect 114 answers to be there. No pressure. So we're with the City of Greater Dandenong, as I've mentioned already. We prominently work with the community groups from Afghanistan and from Myanmar. They're settling mainly out in the southeast, and there are other pockets around the state that are also seeing those settlement numbers, particularly over in the west as well. But having said that, Vietnamese is the most commonly spoken language in the City of Greater Dandenong after English. So it is a very multicultural area, and we have at least 135 different languages spoken in the City of Greater Dandenong. Our team at work are very adept at working with translation services, and we've been very fortunate to have staff members, including Mina, that can speak Dari and other languages as well. So just a quick question to get you all, make sure you're all listening. In Victoria, if children are fully up to date by the age of 4, how many antigens would they have received? So we'll go with non-Aboriginal and Torres Strait Islander at this point.
I know. Can I say?
Not yet.
Not yet.
Take your time. I can hear people going Hexa. 1, 2, 3. Any answers there, Natalie?
There certainly is. We've got a couple of votes for 12. I've got a vote for
12.
10.
Right. And any more?
A few more 12s on the board. It's looking
12.
good.
Okay.
Can I say it now?
You can say it now. Go.
It's 14.
And if they were Aboriginal, Mina, what would they have? 15, yes. So that's 14 antigens that our children in Victoria, or Australia actually, are eligible to receive. In other states, there is eligibility around hepatitis A, which we don't have here in the south. So that's a lot of antigens that we're looking at when we're looking at catch-up immunisation. And so you can understand why you all can find it quite tricky because people coming from overseas and other countries might have had different combinations of vaccines. Sometimes not all the antigens that we have here are included. Australia has one of the most comprehensive schedules in the world. Most people arriving from anywhere or children arriving from anywhere will need something to catch up to be up to date here in Australia. So we're quite fortunate that we do have that funding available and on offer all of those vaccines. But of course, it does make it tricky when we are looking at working with people from overseas to ensure that we do get them up to date in as timely manner as possible with the least amount of injections. Okay. So just as we talked earlier, there was the question around eligibility. The main thing is to remember that when we're working with refugees and humanitarian entrants, that they are eligible for funded vaccines to ensure that they meet, our standards here. And we do vaccinate adults, but generally with an adult, Mina, we would vaccinate them. We would ensure they're vaccinated for
What vaccines? The 5
yes,
vaccines?
what vaccines? Yeah. Yes.
So DTP, polio, Hep B, varicella, and MMR.
Yes.
And if they're under 26, HPV as well.
Yes. So, so it's not the full schedule that we would give to children, but pretty close as well. That is a little bit easier to work out. There's just a link there in that slide that takes you to the eligibility information from the Department of Health in Victoria. And once you receive the slides, all of those links will be live as well. Natalie, we're happy to have any questions as we progress, or if we want to leave it till the end for panel discussion, that's fine as well. So
You're doing such a good job. There's no questions as yet.
sure,
So continue
that's
on.
right. We'll see how we go by the end. So just some tips, some basic catch-up tips that any immunisation given after the recommended age is considered a catch-up immunisation. Catch-up vaccination aims to provide optimal protection against diseases as quickly as possible by completing the age-appropriate vaccinations recommended. Catch-up should be used when an individual is overdue for any required vaccines and they're therefore at risk from disease. As we're finding in the southeast at the moment, we have measles that keeps rumbling around that has been imported, and it's a very contagious virus, and it just is rumbling around. So it's really important to ensure we do protect people as quickly as possible. Just to note that increasing the interval between doses when there's multiple vaccines due doesn't diminish the effectiveness of the vaccine. So if somebody's due for something within 2 months and then it's actually 4 months when they get it, that's fine. It continues the schedule, and you would plan their next vaccines related to that later dose. But by decreasing the interval between doses may interfere with the antibody response and protection. So even though we'd like to get them done in a timely manner, doing it ahead of time that's not recommended can actually impede the uptake of that vaccine. And just a reminder that live vaccines should be given actually on the same day or separated by a month. And this is to reduce interference by the antibody response. And in this instance, rotavirus doesn't count for that because that is an oral vaccine. All the other live vaccines are administered by a subcut or intramuscular route. So when you're getting ready to get started for your vaccines, particularly when we're working with refugees and asylum seekers, we try to get as many of their records together. as possible. I think we've got Larissa online, and Larissa is a fellow, a refugee fellow at the Monash Health Refugee Health Service. They work on that premise as well. I hope she's nodding her head, not that I can see, around that. So sometimes they might come with some hard copy records. Hopefully you'd love to see some records already on the Australian Immunisation Register. But we also use a portal called the HAPLITE, which is the health assessment portal. So anybody coming into Australia, particularly through refugee avenues, have a health assessment prior to arrival in the country, and they have a number associated with that, and we can actually view their immunisation records, but we can also view their health assessment as well. Mina and Harleen, a couple of our team members, have been leading on working with some practices in the southeast around working with refugee clients requiring immunisation. If you look at HAPLITE and the information that you can gather, and that's also a live link there as well, the instructions say it's quite easy to register to get HAPLITE access, but that's a hurdle that we've come across. Isn't that right, Mina? So,
we haven't been able to get any.
We haven't, yes, been able to get any of the GPs onto it. We've been working with them since early February. The Southeast Melbourne PHN have sent a letter to Home Affairs around, you know, it's not that easy. And just for people outside of the Southeast PHN, you do require your local AIMS team. So AIMS are the people that assist with settlement of clients into the state. They need to approve you as a service that will see refugees. So there's a few hoops to go through. That actually is a live link in the presentation. I was going to take you through to it so you could have a look at the information. It does take you through to the Royal Children's Hospital site. Their refugee services use HAPLITE a lot, as do other refugee health services around the state. So that's, I'm sorry to present it to you and say, but you can't have it just yet. We are working towards a process so that you can actually access it, because we find there's a lot of information there. There's often serology listed there as well. So all these things are done, and it just does make it so much easier if we already know some of the vaccinations that they have been administered. And then Mina, I'll click on this. I'll let you talk to this one.
Yes.
I think I can get to that.
So when we come across some histories, especially from like Afghanistan, Pakistan, and that side of the world, we get a different date. So it'll come up with something like the 1400s or the 1395. Like that's the year that they're in, but we're in the year 2024. Over there at the moment, it's actually the 29th of December, 1402. That's their date. So sometimes their dates would be based on that calendar. And this website actually, if you put in the date, it tells you where what's the date. It converts it for you, but it hasn't opened.
Oh, hasn't it?
No.
Oh, okay. So that's what the page looks like though. And so what would I need to click, Mina, to get it to open?
Oh.
So it does come in here. So we've had a couple of practices that have said, you know, when we're looking at the date of this person's birth, it isn't an 8-year-old child, yet it's an 8-year-old child standing in front of us. And this will assist you in converting the date. And as you can see there's different countries that do have different dates there, so that you'd be able to actually look that up. And that's just a website, and that's also a live link there as well. And I think Mina has it as an app on her phone as well.
I've saved it on my saved things on the
No worries. Okay. Oh, I know why it didn't open, because I had it on my other screen. Oh, sorry everybody. Is that better? Yeah.
No.
You can't see it still?
Nope.
No. Okay.
We will include these links too when we send out the resources.
I'm sorry, everyone. That's my fault for that. I'll just get back to this.
I can talk about the Translate app as well.
Yes.
So anyone who has an iPhone or maybe an Android, If you go onto Google Translate, there's a little camera at the top, and that little camera, if you touch it and you give it access, and say, for example, you have a piece of paper with a history in a different language on it, if you put the camera on top of it, it starts translating them for you. They might not be 100% accurate, but they're pretty good, because compared to when I do it on the Afghanistan ones, on the Dari ones, it actually translates to the right thing.
Yeah. So can you see that on the screen at the moment?
Nope.
No, what's on the screen at the moment? Just my presentation?
Yeah.
Yeah. On that presentation there's the live links to the Google app and the Apple version of that app, so that if you wanted to pop it onto your smartphone, you'd be able to utilise it to help translate some of the records as well. So then we also always start with the premise that if there isn't a record available, that then we assume that the vaccine hasn't been given. If it has been given, in most instances, all doses count. So don't start the course again for NIP vaccines. I have got an asterisk there, because you'll often find that clients will come over and they'll have a measles vaccine, but we actually don't count that one because we need it to be MMR as their first dose of that as well. You can still put that onto air if you've got the information, but it does mess up your dose counts, and sometimes in general practice that can actually impede the uploading of the vaccine after you've administered it. So you might want to complete their schedule and then put on any vaccines that might be a little bit out of sync with that. So we always give everything that is due on the day, so that you're making the most of the opportunity of that person being in front of you, because sometimes we don't always seem to see people again. Generally, when we are talking to them and we're getting consent, and we're saying that you're having your catch-up vaccination, and they can get quite a few vaccines on that day, it's important to say that it's not complete today. You do need to come back, because sometimes they've assumed because they've had it that everything's done. So it's good just to be clear about what the process is, and even assist with them to book in an appointment at the time or use your reminder system. The software in general practice is very good for that, so that if you've set it up and use it, it works really well. We use the standard intervals and ages recommended on the NIP schedule once they're up to date. So what we're saying there, once they've caught up and that's all up to age appropriate, they're not considered on a catch up anymore. They're just on the routine schedule. And also just to keep in mind that if antigens that are required that are only available in combination, it's acceptable to give those combination vaccines, because often we find if you've got a child over 5 but they need everything else, they don't actually need the Hib because they're over 5. You would give a hexa. You then wouldn't give them 3 separate vaccines like the DTP, IPOL and Hep B. Just give them the hexa. It's 1 injection and covers them, and the Hib component isn't contraindicated for them. It's just not necessarily needed once they get to that age. We've got tips for planning a catch-up schedule. So this was mainly to show you some of the resources that are available. And I'm finding that this possibly isn't going to show up on the screen. Is this one coming up on my screen now? No. Nope. Okay. Even if I move it across. Okay. So this is all of these links here do take you to the Australia Commonwealth website, mainly based up around the handbook as well. And these will always be the most up to date. So you all know that the handbook isn't printed anymore. It's all of it's online. And that's because anytime there's any changes, it can be updated immediately. And that's the same with these links to any of these resources here. And it just talks about how to assess an immunisation status, the principles of catch-up vaccination, and then there's catch-up resources as well, which are really useful. It can be quite laborious if you're sitting there with the client in front of you. So we'd recommend having a look at all of these things and seeing what you would find useful, and having them just sort of already there as a link or already have an understanding. Mina and Harleen are finding that the practices that they've been out visiting, the practice staff, GPs, practice nurses have been really across a lot of the vaccine processes and catch up. A lot of it's coming down to having time to do it. So sometimes if you know you're getting a big family coming in that are going to require catch up, it's often prudent to ask for their records and everything prior to them coming in, so that you've had time to actually sit down, have a look at everything that you've got and make the plan. Sometimes if you're trying to see the clients on the day and start catch up and do everything, it can be quite fraught and very busy, especially if there's little kids and there's maybe not so happy about having vaccines. It would be, does make it a lot easier. And then you can before you even start, you can already speak to the family around the timelines and that are needed to ensure that they do come back and everything's given on time. And of course, always reporting all vaccines administered to the Australian Immunisation Register. It's important that that's done because a lot of people do require, their children to get into preschool, childcare, and as well to assist with any family payments that would assist them. We do find that a lot of these people are quite vulnerable, and money and things can be difficult to ensure that they can purchase everything they need for their family.
So we might jump for some questions if that's okay.
Yeah, sure. No problem.
Just because starting to get a few, which is nice. So first question is really niche. Is there a similar calculator for the Nepalese calendar around the Arabic one?
I haven't come across any, but I'm sure we can look at it, find it. Yeah.
I was going to say we'll take that on notice and include it in our resources.
Yes. I imagine it would be there when we put in calendar converter, a lot of different sites come up that offer it. We just went with the one that Mina finds the most useful.
Perfect.
And, yes, I'm sure that there would be something online to do that. And it might even be the link that we've got in there, because there's quite a list of different calendars in there. I didn't realise there was, very ignorant of me, that there was so many. So, yes.
All right, wonderful. Getting a lot of resistance from parents when advising to receive all vaccines due on the day, and what strategies does your team use to combat this?
This might be because I can speak their language. I'm just like, it's okay. We're going to do it today. They're like, are you sure? Yeah, always, no problem. And they let us. But I don't know, it might be because of our language that we can get them to do it. But even with the Burmese clients, we haven't had any problems. They will just get it. But what's our approach? We just say that's all we're going to give today. We don't give them a choice. Like, we just say, that's it. You're getting 5 today. Okay.
I think it's in how we approach it, because sometimes I think we're coming there going, we're really sorry, we've got to give 5 today. Well, automatically they're on edge. So we say, we'll give 5 today, and that means the next time you come back, you'll only need 2, and then the time after that, you'll only need 1. So roll up your sleeves, ready to go. So I think if you sort of approach it in a positive way, it does work well. If it is proving to be really difficult, and they're not wanting to, you could consider doing a couple. But just remember that by splitting the schedule or the vaccines, that the stress all starts again. So then they come back again, even if it's for just 2. It's like it just stretches it out. It lengthens the time to complete the catch up. Whereas if you can just get it all done in one day, we have some students when we were going into Noble Park English Language School that could have up to 7. They had really nice sized deltoids, some of these people. And we would do that. And they, if you just sort of approach it like, okay, we've got all your vaccines, this is what we're doing today, and always work in pairs in that instance. Don't be one person giving so many. So you can be giving, like if they're having, say 5, you can do, 2 at the same time, 2 at the same time, then 1. So it does actually only feel like 3. I know they're still being stuck with a needle, but we do find the positive approach that this is what we're giving does seem to work really well. We rarely have any times where people aren't happy to do that, and their actual immune system is fine, is equipped to take on all those antigens. It's not an overloading. If you look at your kids picking up things in the playground and putting them in their mouth, they're getting 10-fold more antigens in one hit. So, yeah. Okay.
I think it's worth mentioning too, Melbourne Vaccine Education Centre and Sharing Knowledge Against about immunisation are 2 really good websites that go through about addressing vaccine hesitancy, which again we'll include in the resources.
Yeah. And
Oh,
also, yeah, just approaching it and then knowing, or before you even start, where you're actually going to be putting your needles as well, because you need to be sort of, once you get started, you need to keep moving with it. Don't speed too much, because you need to ensure that you discard everything straight into a sharps container, so that, you know, there's no mishaps with that as well. Sorry.
that's all right. Is the under 20 catch up for everyone or just Medicare card holders?
That one is for anyone, but no, we know in local government we don't get any funding for anything over the age of 7. And you don't get, I don't know if you get the notification payments from AIR. So it is up, because that came in to cover up for people for the no jab, no pay policy. So it is, but I guess in general practice, you can actually bill an item number for actually seeing the clients. We do try and recommend that people don't do a private billing. It can make it quite expensive, but just to know that it is funded, so that there shouldn't be a charge for the vaccines on top of that as well.
And then a couple of clinical questions. All right. So, is Infanrix Hexa okay for 10 years and over?
Not if you're following exactly the orders. No, it's not. You can't do that, because you wouldn't be covered if there was an incident or anything. There has been some pilot studies done, which City of Greater Dandenong has done. We've done the
Abridged catch-up program.
Abridged catch-up program. We had to jump through quite a few hoops to get permission from the Chief Health Officer. And as we know, you know, most vaccines, if not given correctly, are still okay. But no, I know it is done in at the Children's Hospital in some areas, and sometimes at presentations that's been talked about. But as people out in working in general practice and at local government, no, that's not acceptable. It may change in the future, that could come in, because there's not that many people that would need that, but no, at this stage.
And last one, besides sore arms, is there an increased rate of side effects from having 5 to 7 injections in one drug?
No.
Right.
No, there's no increase. We don't even seem to get a lot of faints with that, and especially with the adolescents. And yeah, we've been keeping good records for around any of the you know, post vaccination, particularly with the Noble Park English Language School. We do some follow up, and the teachers are also aware of it as well. So no, there isn't an increase.
Wonderful. All right. Well, with that, we might go on.
Yes, no worries. Were you doing this slide, Mina, or was I?
You were.
I was, okay. So developing the catch-up. And just to link back to the digital health presentation as well, the correct name is really vital to ensure accuracy of records. So for any of those digital health records, whether it's the My Health record, AIR, Medicare, it is really important to have the correct name, so that when they register with MyGov, that the name that they register with needs to be the name that they log on with, or tell the doctor or whatever. And we do know sometimes that papers haven't come with people, and some of them have got multiple names, and they'll say, oh, just call me Muhammad or something, and actually that's their third name out of, you know, a whole list of names. And then the next time they come to the doctor, they say their full name. So then it goes up to AIR, and it goes up, and a whole new record's created. So this person, we know according to our records they're up to date, but we can't find them on AIR, because every time a record goes up with a different name or a different birth date, it creates a new record for them. So it is really important that we've got the correct name and the correct spelling. That's can be tricky, and that their birth date is actually accurate. And the reason we say that is sometimes if people arrive, particularly under really sort of rushed circumstances, if no documents come with them, they're often given a birth date of the 1st of January of the year they've said that they're born. And then often down the track, we'll actually get official records that will state what their official birth date is. And then people start using that birth date, but all of their MyGov records are actually with the 1st of the 1st So it's really important, if that's going to change, that the client actually needs to do that through MyGov and officially present the documents and get that updated. It can be tricky, but it means then that all of their records stay together and we don't end up with a whole lot of different accounts for that same person. We need to work out the age accurately, as somebody's already mentioned, about being 10 years or under. So we do know if they're over or under 10, that changes the vaccines we give. And then for infants, we talk about it in weeks and days. Probably with the refugees and asylum seekers, we don't work a lot necessarily with infants. We're actually with children, adolescents and adults. As we mentioned earlier, we build on previous doses. We look at the number of vaccines that are required and then what is not required. So as I've said, we don't work a lot with infants, so we wouldn't be giving rotavirus at any of our sessions where we were focusing on refugees and asylum seekers, whereas at our general sessions, we definitely would, because they would be arriving there for vaccines. And catch-up schedules need to be developed by qualified staff. So it needs to be a nurse requires a doctor's order if they're not a nurse immuniser, and a nurse immuniser can develop a catch-up schedule if they're going to be administering the vaccines. And as we've said, the doctor's order is required for other registered nurses or enrolled nurses that are endorsed as well. The doctors do rely on the nurses a lot, I think, in some of the settings to provide the immunisation catch-up. And I recommend that if that's the instance and you'd like to do an immuniser course, I'd really push for it. It just gives you that extra level of information and understanding. And if any GPs are online, please support your staff to do that as well. It does make a big difference, and just in confidence and that as well. And then they can work independently. But of course, if the nurse immunisers develop the catch-up and is administering, you do still need a doctor's order so that you can actually then do the item number for Medicare, because a nurse immuniser wouldn't attract any funding for that or billing. So this is just so that you do have the links to the tools that we use. The translating overseas immunisation records aid is to utilise as well, but also, as Mina talked about, that there's the app that you can use that can translate with using your camera. The vaccine side effects is fantastic. We recommend that for everybody. We give every client a copy of the post-immunisation handout that the Department of Health do. We give it to them in English, and then we give them the same information in their language that they can read, or somebody in the household might be able to read. We do always give the English as well, because if they do end up at a health service or somewhere else, they do have the English that they can show what they've been given as well. But that explains it, things really well. And then also we'll provide our templates that we'll have them in soft copy. And I think we've sent them to Yvonne, or we're sending them to Yvonne, who'll get them out to you. So we have catch-up templates that the team have developed, and that's for under 10 adolescents and then adults as well. And that really, you'll see some versions of that coming up, just makes it so much easier to see what we're giving today, what have they had, and what are their future vaccinations going to be. And so this can be used not just for refugees and asylum seekers, it can be used for anybody requiring a catch-up. So over to you, Mina.
Okay, so a typical scenario for under 10-year-old arriving as a refugee from Afghanistan. So we've got Zara, she's 3 years old, and the documented immunisation history that she's come with is 1 dose of measles, mumps, rubella, which was given on the 7th of January 2022, and 1 dose of polio given on the 6th of March 2021. So we want you to have a think about what we would be giving the child today and what we'll be giving the child next. And I would like you guys to actually answer that for me on the chat, please. And usually with like, this is one of the most typical things that come up, measles and OPV. Sometimes I'll come with a MMR as well. And as long as they're given over the age of 1, we can count it. But if they're given under the age of 1, we won't count it.
There's a tip.
Anyone? No one?
How's it going, Nat? Come on, Harleen, throw it in.
That's all right. Everyone's got their thinking caps on. This is good.
Fine, we'll tell you. No, no one.
It is tricky.
We got an answer, yay!
All
We got
right. Well,
Hexa, Prevnar, and MMR. That's awesome.
Okay, I'll move along.
Yep.
Okay. I can't see the answers coming in. Is
Okay.
that big enough for everyone to see?
all right. We also have a meningococcal ACWY in the Q&A section. Very good.
So the reason we give MMR and not MMRV is because we give MMR under the age of 3 first. And then after they turn 4, then we can give the MMRV first. So MMR first under the age of 4, or MMRV up first after the age of 4.
So we would give 4 vaccines on when Sarah came in for this time. And as we said earlier, she has had an oral dose of polio, but it's easier to give the Hexa. We may as well give all the antigens that we can in that one vaccine. And the pneumococcal, of course, and the MMR and the meningococcal. So well done, everyone.
I just want to say with the pneumococcal, I could never remember that I had to give 1 dose under the age of 5. That took me forever to get in my brain. And today with the Hib, we were looking it up on the Australian handbook going, what do we do with the Hib again? Because, you know, the Hib on its own is so hard. So we're always looking back at the Australian immunisation handbook.
Yeah. And that's good to know that it's okay to sort of go, what is that again? To go back and look. We're fortunate in that we're in a whole team together that we can all have these discussions, but sometimes we understand in general practice you will be often on your own there as well. So does anyone have any tips on what we might give on the second visit?
Which is in 1 month's time.
Okay. I might move ahead. I just noticed the time. So for Zara?
Yep. So 1 month later, we'll give the Hexa and the MMRV. And then 3 months after, we will give the Hexa again. And the only reason we do the Hexa after 3 months is because the hepatitis B component. The hepatitis B component, you need the 4 months from dose 1 and dose 3. And then from dose 1 and dose 2, it's 1 month. And from dose 2 and dose 3, it's 2 months. So it's very confusing. So we just always give it 3 months later.
Yeah.
And then after about 6 months, we give the 4-year-old vaccine because this child is going to turn 4 soon anyway. So we may as well just wait. Instead of just giving the DTP on its own at 6 months, we'll wait until she turns 4 and we'll give her the 4-year-old vaccine.
So after that 3rd visit, she's actually up to date, and then she'll just time into her 4-year-old vaccine. And if she had the 3rd dose of Hexa after she was 3.5, she wouldn't require the Infinrix IPV.
No, she would.
If it's after 3.5?
They'll still just need the DTP.
DTP. Oh, sorry, the DTP.
6 months later, definitely, yes.
Yes, sorry.
Yeah.
And also with that one, Mina, would we be recording the measles and the polio on air?
I wouldn't. There's no need.
Yeah.
Doesn't do anything. Yeah.
And because any of the measles vaccines that are given under 12 months of age really aren't considered their first dose.
Yep.
So here we have Moe.
So Moe is 13 years old, and the only thing he's come in with is 1 dose of polio, and we want to know what you would give today.
Yeah.
13.
So he's 13. I'm sure that boy's 13 in the photo.
Yeah, he looks 13. The next one doesn't.
Yeah. We better just keep moving, do you think, Natalie? It's time's getting away. So Moe, we would give, is that one clear as well? So this is the one that a lot of people would go, oh, I can't give that many injections. But we would always give that many. So I'll let you speak through it to that, Mina.
So yeah, just as you can see, we've got the 3 doses of the DTP. We're going to give 2 doses of polio because, not obviously in one go, but that's what's remaining. Okay. And then the hepatitis B. So I put this one up because anyway, you can get 2 doses of adult Hep B 4 months apart, at least 4 months apart at the age of 13, up until the age of 13, 14. That's why I put this one in there. And yeah, same with the rest is just all the same. So with the MMR-V, up until the age of 14, they can have MMR-V, but after the age of 14, they need MMR and varicella given separately, and 2 doses of each. And then once they're 14, they do need 2 doses of the varicella. We would recommend for a second dose of varicella, but that would have to be paid for if in this instance for anybody under 14. And then we've got Mina, cool Mina, who's 59. And then I've just highlighted there the birth date, the 1st of the 1st, just to be aware that that can always be something that can be updated later on as well. So Mina's got varicella immunity recorded. So what would you give her today after we've made sure we've checked birth date, all of those things as well, and the spelling of her name, because cool Mina, we might actually question if that was her actual name. Okay. So we don't actually give MMR because anyone born before the year 66 doesn't require an MMR vaccine, and they also wouldn't need any testing done for it really, because everyone before that year would have had MMR. So we don't give MMR at all at that age. We will, and we won't give any varicella because they've been tested for it, but we'll give the 3 doses of the DTP, the polio, and the hepatitis B. Yeah. So that one's there as well. And the doctors, you can test for Hep B, varicella, and MMR, as long as they're over the age of, we say about 19. We don't really do it for anyone under. Yeah. And if you do serology, please record it on air, because anybody looking at their records would think that they were overdue if the serology isn't recorded that they're actually immune as well. And with the Hep B, if they have had a dose of Hep B, to wait, I think it's at least, I'm not sure how many weeks to do the serology, because some people seem to give the Hep B and do a serology quite close, so it will come in that they are immune. But we want to know that down the track they have actually seroconverted. So you need to give it time for it to be an ongoing conversion as well. So that's a copy of our general template, and we'll send that out with our resources so that if anybody would like to make the most of using the templates, they're available there for you to use. It is up to date for now, and unless if there's ever any changes to the schedule, of course, it would need to be updated or rejigged for that as well. So then other resources that we use, you'll see on the screen there, the immunisation catch-up calculator. That's really good. I think they've actually expanded it from kids over 10, because it used to be only up to kids that were 10. But I might have been dreaming about that, but it's definitely really good to use for children up to the age of 10. The Department of Health in Victoria do have some really good resources there as well. And already, as we've mentioned, the translation resources for handing out to the clients. We find it's always really good to hand out what they've had on that day, what limb we've given it into. And as well, we'd always make sure they've got it documented at the date they're due to come back for that vaccine. And the reason we do give hard copies to them as well is so that if they actually can't read it, if it's maybe not in their language, or that somebody else can actually look at it and read it for them as well. And sometimes people will attend our sessions and bring a relative that does speak English to assist with questions and consent as well, although we do prefer to use translators and interpreters for that if if it's going to be more than just a simple conversation.
So they're the links from the presentation. And then this is just some 10 tips. Dr. Larissa Whale from the Monash Refugee Health Service put these together. The people in the southeast area with the PHN would have already seen these. And these are just tips to assist with ensuring that you get the best out of any of the visits that you have with your clients. And it includes actually working with the clients for not just immunisation, but meeting their other needs. There is a refugee health assessment that can be done in their first 12 months of arrival. Monash Refugee Health Service will often see our clients that in our area prior to them being referred to general practice, and they're not actually billing. They're trying not to bill those refugee health assessments, so that then the general practice can actually bill them, because they actually do provide a larger income and based on time for the nurse and the GP, so that that might assist with some of the time spent on planning a catch up as well. I'm not sure. I'm really sorry for the Northwest of what the process is out there and where your clients might be being referred from into you. So looking at using the refugee health assessment, looking at pathology screening, and that, of course, a lot of pathology may be in the HAPLITE, in the health assessment portal, which we will, as soon as we've been able to get GPs onto that portal with more ease than we're finding, we will let the PHNs know about that, so that they can assist with any support in that area as well. And they're just the last ones there. So looking at other aspects of their health as well. So there's dental referrals to Foundation House, using literacy resources, and of course immunisation. And there's other regional contacts there for everybody, so that you can see there in the 10th tip where your services might for refugee health might be available wherever you are around Melbourne or Victoria as well. So we wish you happy immunising, and hopefully your job's a little bit easier than this guy, who is very committed to ensuring polio got out to every child, I think in the north part of Pakistan. And we'd just like to acknowledge the Prime team at City of Greater Dandenong, and of course Larissa Wales at the Monash Refugee Health Service. So thanks everybody. We're sorry we've gone close to time for that, but we're happy to take any further questions.
Okay, so there's just a couple of, again, some clinical questions. So I think a large amount of them are about combination vaccines, and when you would or wouldn't consider using, for example, a Boostrix IPV as opposed to a Boostrix and standalone polio. Sorry.
I think from the Department of Health, I'm not sure if Boostrix IPV is actually provided. So we would be using what can be provided through OneLink, which is the Department of Health resources, and we're working with people that we're assuming aren't paying for their vaccines, whereas I think a Boostrix IPV is not funded. But I would always, if I was able to give combined vaccine, so it's a one less needle, that's fine. But we're working with product that we can get through the Department of Health. We used to be able to get Boostrix IPV a long time ago, but that's not on the order list now. But that would be relevant to give if you have it.
Around eligibility for vaccinations, if serology has been done and it's come up that they're not immune, but they've documented as having the vaccination. So this is around MMRV or hepatitis B. How does that work in terms of eligibility for NIP funded vaccinations?
I think if they're coming in as not immune, you would vaccinate, because possibly it would be a cold chain breach or something that the vaccine wasn't valid, particularly if you have the serology. I'm not sure how that goes with funding, because that would then goes up onto air and whatever. But they're, if they're not immune, they need to be immune. So I would be vaccinating. And I guess if it's questioned, you could say that serology was taken and it was negative.
Oh, and there's
They're
also
important to be covered.
there's a list of countries, if they come from that part of the world, anyone coming from that part of the world, whether they have a Medicare or not, they're all eligible for Hep B. There's a list on, I don't know where it is though, I forgot where it was, of all the countries that are allowed, and there's heaps of them.
Yeah, it's most of Southeast Asia or most of Asia, Africa, and some of the Eastern European countries are eligible for Hep B just because of the high risk of transmission in those areas as well. That is available on the Commonwealth website on immunisation. I think if you put in Hep B eligibility, that would come in. I'm not sure if that's on the Victorian side or whether I think it's the Commonwealth site.
I'll see if I can find it.
Okay.
It is on the Victorian website too.
Victorian, yeah.
You can always send it out with the post-session resources as well, once we have the link.
Thanks, Yvonne. Yeah.
All right, wonderful.
Any other questions?
Sort of a question around where parents are separated and one potentially is not pro-vaccination and one is, and how we manage that. I think that's more of a question to certainly pose to your indemnity insurer. They can always provide some advice. Also, Melbourne Vaccine Education Centre has some resources around that, tackling that as well.
Yeah, it would. They're always difficult scenarios. I guess, they're things that they do need to sort out. Having said that, legally, they'd land on the side of the parent that does want to vaccinate, because I know children in out-of-home care, their guardians don't have to give consent, just the person caring for them at the time. That was a legislation change for that to happen, because the courts felt that it was within the child's best interest. But I would suggest not getting caught up in that, but also you need to ensure that there is consent given for that. And I think sometimes that happens. I think occasionally we see that at schools, that the one parent has said yes to HPV in Year 7 and then they've said to their other parent, I don't want to get my vaccine. So it can prove to be difficult, but that's often something for them to sort out. And then if one parent is considered the primary caregiver, like has more legal rights, you probably need to side with that.
All right, wonderful. Well, I'd like to thank all our speakers this evening. It's been a really interesting, and I hope everyone's found it a really useful session. There is a conclusion slide, which I'll bring up when my computer would like to wake up. It's feeling like all of us, I think, a bit rusty towards the end of the working day. All right, let me just pop this up for you all. So you will receive an email within a week that it will include slides and resources. As discussed this evening, you will get an attendance certificate within 4 to 6 weeks. So please just ensuring for the last time before you log off that your name has been changed to your correct name with your Zoom profile, or likewise pop it in the Q&A section and we can follow it up from there. For those of you who are GPs, your CPD points will be allocated within 30 days as per the requirements. So I'd like to thank everyone again and wish you a very happy immunising evening.
Thanks, everyone.
Thanks all.